Where's your turtleneck?
Oh, yeah, that's true. I should have. I could have worn the black turtleneck.
Hello and welcome. I'm thrilled to have everyone here today. I think you're able to hear me even if I'm not kind of leaning into the mic. Let me know if you're not. I'm Stacy Steinbach with the LGBT Center. As folks are coming in, congregate towards these tables that are here in the middle, and the table that you're at, make sure that it has a case study sitting on it. So like this table over here is a great one to join this gentleman here eating at. I'm not sure if you all over there have a case study. So just make sure that you're sitting at a table with a case study. You may need to move yourselves over to another part of the room if you don't. So I'll give you a few seconds to do that. Okay. So I'm really excited today to be presenting a session of the certificate series that is also medical education grand rounds, and so co-sponsored by folks that we work very closely with in undergraduate medical education and our research office there. And together we are developing an infusion project of LGBT and DSD, or differences in sex development, into our undergraduate medical curriculum. And I just want to honor Susan Sonning, who's sitting here, one of my colleagues that I work very closely with. Susan, give us a little wave. Come on. She's very understated. And thank her for her support in helping put on medical education grand rounds for us today and combine it with our certificate series. If people have any questions about how to earn a certificate, please feel free to talk with me. I have some kind of directions here that you can also find on the LGBT Center's website about doing 5 sessions and making sure that 3 of them are interprofessional sessions. Today is an interprofessional session, so that counts. Yay, you're here. You can also watch these sessions. We're recording them, and so you can go to our website at the LGBT Center, click a link to watch the recording, and then click another link to take a survey where you answer some basic essay questions about what you learned from that, from watching the video. So know that those are also options available to you. I also want to recognize that this is Pride Week here at U of L, and so the LGBT Center where I work, we help to coordinate those Pride Week activities. So I'm going to recognize a few of our sponsors, and if you are people who either work for these different schools or offices, or if you are affiliated with them, just give us a little hoorah. So anyone from the School of Dentistry, I've seen a few of you. Hurrah! Yeah, look at you representing. That's awesome. School of Medicine, are you out there? Yeah, great to have you. We've also got the HSC Office of Diversity and Inclusion. Do I have any of our colleagues from that office here? Not right now, but they have been very generous and supportive of us as well. And School of Public Health and Information Sciences, are you out there? Good, awesome. And finally, do we have anyone from Information Technology? I know we've got some folks in our room over here. Yay, so we have them too. So those are some of our many sponsors for Pride Week. So great to have you all here. One of our last activities for Pride Week will actually be bowling at Vernon Lanes, and this is a student-sponsored event, and it's meant for students. But students, if you are interested in that, let me just scroll down real quick. Here are the folks to contact. These are 2 of our leaders of the student groups. We've got Marlo Diekman and Ross Savage. And so please contact them to find out how to do all you can bowl for $15 Friday night. Okay. So I'm going to introduce our speakers now. We have wonderful speakers with us today presenting on understanding LGBT health disparities, and specifically what we can do to positively impact those health disparities, because that's really the crux of it. So we have with us Dr. Lori Kaloya, thank you. She is a family medicine doctor here in Louisville, Kentucky. She received her medical degree from Michigan State University College of Human Medicine and has been in practice for 11 years. We've been very lucky to have her here at U of L's Campus Health Services office on the Belknap campus for the past 2 years, and has just recently transferred to the family medicine department here at the School of Medicine in August. Dr. Kaloya has extensive experience in community-based health healthcare. She has completed a public health leadership certificate at Eastern Virginia Medical School and an LGBT health competency certificate through the LGBT Center here at the University of Louisville. So this that you are currently engaged in as well. She currently serves as member at large on the American College Health Association Coalition of Allies for LGBT Health Executive Committee. Thrilled to have you here and helping lead us in our educational experience today. We also have Dr. Eli Pendleton, who has received his medical degree from the University of Kentucky College of Medicine and did his residency training at University of Virginia, where he also completed a fellowship in faculty development with a focus on evidence-based medicine and information mastery. Dr. Pendleton joined the Department of Family and Geriatric Medicine in 2010 and is the medical director at Newburgh Clinic and associate program director for the Family Medicine residency. I'm thrilled to have them here with us today. I'm turning it over to them. Thank you.
Thank you, Stacy. First of all, can you all hear me on this microphone or no?
No.
I'm not sure.
Okay.
Yeah.
Let me try again a little bit closer. Can you hear me with this? No.
Is it on?
It is on. So maybe it's dead. So we may have to improvise. Can you hear me with this microphone? All right. I hate being stuck here, but that may be where I have to be in order for you to hear me. So all right, well, thank you all for coming today, and I appreciate that we have people from a variety of different allied health professions. We have some people who are administrators, which I was actually really excited to see. And so, again, I appreciate all of you being here today, and hopefully you can all learn something about LGBT health disparities and how you can help to change these and improve these. When I think of health disparities, I think of achieving health equity or optimal health for all people. And so our goal today is to improve health equity, and usually we think of that at a societal level, but hopefully today, like Stacy was saying, you will leave with some tangible skills and more knowledge in order to be able to bring that back to your office, to your practice, to your everyday life in order to improve these health disparities of lesbian, gay, bisexual, and transgender people. So by the time you leave here today, you should be able to describe health disparities of LGBT people throughout the lifespan and describe how health professionals can reduce barriers to care for LGBT people in order to improve these health disparities. And then also, how can we, as health professionals or administrators, also provide culturally competent care to the LGBT population as a whole? And in order to talk about health disparities, I think we need to define what a health disparity is. I think most of you know what this is, and the Center for Disease Control in the report Healthy People 2020 defined this for us as a preventable difference in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And as we know, and as you'll understand even more by the end of this talk, the LGBT community has been one of these disadvantaged populations. So when we think of health disparities, we think of a variety of factors historically. So we think of racial and ethnic disparities. We think of gender differences, whether male or female, or people that may not fall neatly into those gender categories. We think of people with lower educational levels, lower socioeconomic status. We think of people with disability, such as physical, cognitive, and sensory disabilities. We think of different locations and how that may play an impact on health disparities. So we hear a lot recently on the news about rural areas being affected by certain things. And then also here in Louisville, we see day to day how even when you live in an urban area, where you live in that urban area may affect your health outcomes. And then this slide did not end up the way it should have when I transferred it over, but and today we're specifically going to focus on those gender identity and sexual orientation health disparities. So some of you may say, and most of you here probably won't say this, but other people may, but you'll say, why do we focus on LGBT health disparities at all? And what this map is supposed to show you is that this is a fairly sizable population of people in the United States. Current population estimates, which are probably underrepresentative, say that there's about 3.5% to 4% of our population that are lesbian, gay, bisexual, and transgender. And this is a population that, again, is usually underrepresented, but sometimes people don't consider themselves one of those neat categories. So even though 3.5% to 4% of people make up our population that are LGBT, there's about 8% of people that may have had same-sex sexual contact, and there's about 7.5% to 11% of people that may have same-sex sexual attraction. So this is, again, likely an underrepresentation. That 3.5% to 4% of people is about 8 million people in the United States, probably more. And of that, our transgender population in the United States is about 0.3%, and that's about 700,000 people in the United States. So in my clinic, I see about 25 people on average in a day, and based on these statistics, at least one of them is going to be lesbian, gay, bisexual, or transgender. And again, that's underrepresented, so it may be that it's more than that. So even though we talk about the population at large and how, there's 3.5% to 4% of our population that are LGBT, I think the important thing to remember is that lesbian, gay, bisexual, and transgender communities are diverse, but that every person in those communities is also an individual. So although we can categorize people and say that there are unique needs in each category of the LGBT population, based on individuals and their own behaviors, just as in the non-LGBT population, that can have an impact on their health as well. So we know that LGBT communities, people come in many different packages. They come from all walks of life, all socioeconomic backgrounds, different ages, religions, races, ethnicities, and abilities. But what I've seen in my experience is that they all have a common experience of stigma and reduced access to appropriate care. So that's the main reason why we're coming here today, is to address that. What I've found, though, as I've encountered more and more LGBT patients, is that they have a magical resilience despite what they have been through. And some of that is internal. Some of that is based on the strong community that they have had to turn to in order to survive. But I think that those are factors that also positively can impact their health and help to improve the health disparities. So we have some public health people here. We have some nursing people, we have medical people, dental people, we have administrators. And I think you can see this across a wide variety of areas and not just in healthcare, but so health disparities, but also experiences in general can be affected by multiple things. When we talk about health disparities and specifically those of LGBT people, today we're going to talk about three things. One, the social determinants of health that contribute to this. Two, the biases, whether overt, whether subtle, that can exist in healthcare. And then also about the stigma and discrimination experienced by LGBT people in general that can affect their access to care and their health outcomes. So in the health disparity world, access to healthcare is a huge thing. And what we know is that people in general, when they have a healthcare provider, whether a nurse practitioner, a physician assistant, or a physician to go to, they tend to have better health outcomes. And what this slide represents is that if an LGBT person does not have that provider, they're going to have worse outcomes. And as you can see, it is much more likely that an LGBT person will not have a regular provider to go to. And that disparity is seen more frequently in women. If they do have access to healthcare, LGBT people are more likely to have a clinician who is lacking in understanding of their cultural and their healthcare needs. So how many of you, when you've gone to your own physician, have been asked about your gender identity, have been asked about your sexual partners, about your sexual behaviors? I know I haven't. Sometimes things can be presumed. And so I think without knowing who our patient is, often it's difficult to know what sorts of things we should be telling them about. What are they at risk for? What sorts of treatments or screening tests should we be providing for them? And without asking those questions and understanding what health needs are for those different populations, we're missing a big chunk of good medical care that we can be providing. Even when LGBT people have access to healthcare, they have a healthcare provider they can go to, their healthcare provider is knowledgeable about their specific healthcare needs, they also face additional things that can contribute to their difficulty in getting access to care. I had one of my transgender patients several weeks ago, actually several months ago now, say to me, I'm not sure I'm going to be able to come to my next appointment because my car broke down. And I said, oh gosh, and not thinking, I said, well, do you think you could take the bus? And she said, I don't really feel comfortable doing that. And instantly I felt silly and ashamed that, I didn't think of the fact that she might be facing risks by taking a bus, that she's worried that she might be assaulted or might be treated poorly because other people would know that she is not a woman at birth. So I think that really hit me as far as the complexity of these different situations on access to care. We also know that LGBT people are at higher risk for poverty, homelessness, social isolation, and rejection by families, and people in the community contribute to that. So in a perfect world, when we all have a healthcare provider and we all have easy access to care, there's still the small factor of actually paying for that healthcare. And traditionally and historically, what we've seen is that there has been a lack of partner coverage by employment-based insurances. This is certainly discriminatory. And I know at U of L, we've done a lot to try to improve that for our employees. But this is still something that's faced throughout the U.S. The Affordable Care Act has actually done a lot to improve this and made some requirements as far as healthcare coverage goes, but we're not there yet. As you can see, there's still a large portion of LGBT people that are uninsured, although in a hopeful manner, the poorest LGBT people are being covered by insurances that have been provided through the Affordable Care Act. So there's a glimmering small light at the end of the tunnel. And this shows there's about a 4% difference between access to health insurance between LGBT and non-LGBT people. But one thing I've encountered again and again when talking to some of my patients is that even when they have access to health insurance, sometimes it doesn't cover the necessary services. So my transgender patients in particular, there are some insurances that still discriminate and will not pay for required hormonal therapy or surgeries that, in my opinion and the opinion of many, are required medically. They're medically necessary procedures. Some of the concerns for bureaucracies are that these are costly procedures, they're costly medications, but what we know is that if we provide these services for our transgender patients, they're more likely to have better mental health outcomes and lower rates of substance abuse. So in the long run, we're probably saving money for the healthcare system by providing these necessary medical services. So aside from the access, side of things when it comes to health disparities for LGBT people. There is a huge area of bias, and I know, talking to some of you in the audience, some of you do some work with health disparities and may look at health bias in many different spectrums of medicine. But in LGBT health disparities in particular, there's definitely bias. Sometimes this is subtle. Sometimes people they're not aware of it. They don't recognize that they have bias when it comes to taking care of LGBT people. And this Kaiser Family Foundation study showed that about 6% of physicians admitted to being uncomfortable treating LGBT patients. That transgender part of things was not included there. When asked about their comfort level with asking questions about sexual orientation and gender identity in adolescence, medical residents, about 70, so 3/4 of them, or 2/3 of them, said, I don't feel comfortable asking these questions of my adolescent patient. So as a healthcare provider, as a physician, I'm afraid to ask these questions. How am I ever going to find out the information I need to know to improve these health disparities? And then our own students have been discriminated against and have had to face a hostile environment in order to achieve their goals. This study was particularly done in medical students, where about 17% of LGBT students said that they felt like they had experienced a hostile environment going through school. This is a Lambda Legal study done in 2010, and what this showed is that the experiences of LGBT patients as well as transgender patients are ubiquitous as far as experiencing discrimination as well as substandard care. So the vast majority of the patients or people surveyed said that their healthcare providers were unaware of their health needs. They also felt like they were treated differently and provided worse care or substandard care, and many of them were refused care outright. Some of them were treated with harsh language or even physical roughness when they went in to be treated by their providers. And they also experienced excessive precautions taken on the part of their healthcare provider. So some of them reported not being touched at all by their provider, and many of them said that their providers put on gloves in order to do exams that they wouldn't ordinarily have done that for with other patients. So this, I think, somewhat addresses those subtle biases that sometimes we as healthcare providers or allied health professionals don't even realize that we're taking these steps, and recognizing that can go a long way. So within the healthcare arena, but also in the community in general, there are many negative repercussions to being an LGBT person. So they experience harassment, assault, and bullying at a much higher rate. There's corrective rape that occurs in institutions, and even the fear of murder. All of these things can lead to minority stress, which alone can worsen health outcomes, even when you control for other variables such as socioeconomic status, education level, et cetera, et cetera. Okay. So health disparities are experienced throughout the life course for LGBT people, and different stages of life will often require different things, and there's different health disparities during those stages of life. I think back to my own adolescence, and I think what a joyous experience that was, trying to negotiate, developing a personal identity. We as adolescents are experiencing new social, new sexual things, and I imagine what that would be like if you were also questioning your own identity or your own sexual orientation. And the complexity to add into that is now you also are experiencing this in a world where people have a certain expectation of what other people are going to be like. So they have in their minds that everyone is a cisgender, heterosexual person, and so that stigma you start to internalize as an LGBT adolescent, and that can have significant impact on your health outcomes. The other question at this age is also about coming out. I look back to my adolescence, and one week I may have been friends with someone, the next week, we might have been in a fight, and to think about how to figure out who you can trust to come out to as far as your friends go. And then even your own family may not be accepting of who you really are. So all of these things can add to those health disparities for children and adolescents and increase their rates of many things. So homelessness is much higher in LGBT youth than it is in non-LGBT youth. About 20 to 40% of our homeless youth are LGBT. So think there's only 4% of our population that's LGBT, but 20 to 40% are those homeless youth. They're at higher risk for depression, anxiety, and they're 2 to 3 times more likely to attempt suicide. They have higher rates of STIs and HIV, and that rate of HIV is much higher in gay and bisexual men of color. LGBT youth have higher rates of smoking and substance use, and they also have an experience of higher rates of violence, harassment, and bullying in schools. About 3/4 of middle schoolers and high schoolers that are LGBT report being bullied in school. And in a 30-day period, in a 30-day period, 30% of them will miss at least one day of school because they're worried about how they're going to be treated. They feel unsafe or uncomfortable. Early and middle adulthood also has its own challenges as far as health disparities go for the LGBT population. LGBT patients in this age group and older age group often delay or don't seek medical care. They've had bad prior experiences, and this can definitely affect their willingness to seek care in the future. Lesbian women are less likely to receive recommended cancer screenings. So pap smears, mammograms, they often go without. That can lead to higher cancer rates later on because we haven't detected things early enough. HIV and AIDS is becoming epidemic in this middle and older age group. About 75% of our seropositive people are now over the age of 40. And this population continues to grow. About 29% of our people living with AIDS are over the age of 50. And LGBT people, particularly transgender people in the middle and older age, are worried about what's going to happen as they age. They know that there's not adequate healthcare providers who understand their health needs that will be available as they get older to provide necessary medical services. And later in life, as our population as a whole continues to grow, as the baby boomers continue to age, our LGBT population is going to get older and grow as well. So as of right now, there are about 3 million LGBT people in the United States, again, and possibly an underestimate, that are over age 55. And they've experienced, again, poor interactions with healthcare providers. 40% don't tell their healthcare providers about their gender identity or sexual orientation because they're afraid of being judged. Older LGBT people are also at higher risk for social isolation. They're less likely to have parents or children that can care for them as they get older and sicker. And they're less likely to receive services such as caregiving when they're ill or bereavement services for loss of a partner. So this seems like a lot of doom and gloom, and I don't want us to end with that today. There are, I think, the positive side of all of this and talking about health disparities in the LGBT population is that more and more as days and weeks and months go on, there are a plethora of resources out there for us to educate ourselves, for us to learn more about not only health disparities, but how to provide adequate care for the LGBT population as a whole. Here are a conglomerate of things, and as you came in, I know they were handing out a list of resources and also a top 10 list of what you can do to provide better care, not just to LGBT people in general, but to anyone who may be different than yourself. So I encourage you all to look for these resources, even if it's just something here and there, or a dabble here and there, I think you'll learn more and more over time, and you'll feel more comfortable and more confident in your ability to help the LGBT people that you encounter every day. So our next part of this talk, I'd like to give you guys an opportunity for questions or comments if you have any. And then after that, what we're going to do is we're actually going to have you guys break up into small groups. We already have you situated there. If you know everyone at your table, we'd like you to separate from them and try to meet some new people and go to a group of people that might have some differing knowledge than you. So if you're dental students and you're all together, you may try to find some medical students or public health people or nurses. And each table has a case. And so what you're going to do is you're going to go through that case, and Eli and I will walk around and we will kind of help navigate those cases with you. And then at the end, we're going to have everyone from each table kind of give a few comments about what you all determined or came up with during your conversation about these cases. So with that being said, what questions do you all have before we break up into groups? Silence. Yeah, good.
Both of you guys seem to be like have medical knowledge in this subject. Where did you pick up the majority of that knowledge?
So I'm really glad you brought that up, because I was going to start off my talk by saying 2 years ago, I would have told you I was sitting in your shoes with a blank look or in your chair with a blank look, and I knew nothing, to be honest with you. I think in the past 2 years, fortunately for us, we have the great resource of the LGBT Center, and I took them up on their offer of the LGBT health certificate, and so I was able to educate myself a little bit at a time that way. And as I did that, I learned about these resources that were available, and I put myself out there to patients who are different than I was, to be honest with you. And I think one of the things that I've heard from my patients is they said, you know what, I experienced something different when I came in to see you, and that's that you treated me like I was a person, and that my gender identity and my sexuality didn't matter to you. What mattered was who I was. And so that was an important thing that they told me. And I know Eli's experienced a very similar, I think he's had a lot of feedback along the same lines as far as, treating everyone with dignity and respect, and that goes a long way. And then educating yourself.
So like clinical knowledge, like about hormone transplants and stuff?
Hormone therapy, yeah. Again, there's resources out there, and your list of resources, I put a few of those things on there. Some of it was learning. I'll be honest, I didn't know about this, and I had patients come to me and say, can you prescribe my testosterone? And I said, I don't even know how to do that. I'm going to have to do some reading. And so part of it was just an honest answer to my patients and saying, you know what, I don't know enough about this, and that's my fault, and I need to learn more. And then finding those resources to help me. And there's several listed on there. I know this San Francisco UCSF has a transgender clinic that's kind of, I think that's a model for most transgender and LGBT clinics in the United States, and they have an online guide to how to provide hormone therapy for transgender patients. So that was one of my first resources to go to, and knowing I didn't learn any of this in medical school, I had literally a 1-hour session about anything on the gender or sexual orientation spectrum. And so I didn't get taught any of this. And I find that's a common experience, which is why we're trying to change that in our medical school here. But don't be afraid because of that. Don't let that stop you. And a part of it has been a networking thing as well. So I've been meeting people who know more about LGBT health and just using them as a resource as well. So don't be intimidated. Yeah. So I don't. I'd love to. I do know Ryan Coombs, who's over at he is now at Public Health, I think. I know he has done a lot of health disparities research, and he actually, he does different research than this now, but he did a lot of research previously in this area. And if you want his information, I may be able to get that to you, but Yes.
Mind using the mic? I don't think people can hear you, but if you just press on the little
Button here on the
Oh, does that work?
There you go. Perfect. Yeah.
Oh, they really made this nice. My question was about maybe transgender resources in Louisville. I am not familiar with what there is in Louisville. I'm from a more rural place originally, and I was wondering what resources for, proper hormone therapies or surgical resources they have in Louisville, or if we usually tell them, or if those don't really exist and we usually have to send them far away for that kind of treatments. And
So I think what we have is an informal network of providers that have been providing hormonal therapy for transgender patients. I don't know of anyone locally who has touted themselves as a surgeon in transgender surgeries. I know there's a lot of places in the US, and we can talk offline about specific places that I've gotten feedback from. I think there's in the transgender community, there's a lot of talk amongst themselves about who you should go to and where they've had good outcomes as far as both local healthcare providers and also surgery throughout the United States and even abroad. I know the LGBT Center has collected a list of LGBT-friendly providers. I don't always get feedback that's positive on all of those providers, but I think that's a place that often will start. And I usually request from my LGBT patients feedback on different people that I have referred them to, because if I send them somewhere and they have a bad experience, I need to know about that, or else I'll keep sending people there. And also, what was their experience? And maybe that's something I can talk with that specific provider to and say, I appreciate you're providing these services, but I need your help, and these are the things I've seen that have been going wrong. So no, we don't have anything yet. That would be a great thing in the future, but as of right now, we don't have any specific provider that does transgender healthcare by itself. Good.
And I'll just kind of ask the room if there's any other voices of wisdom out there that want to add to that. Just take a minute to see if there's anyone who wants to add. I completely concur with Lori on that, but there might also be some resources we're not aware of yet.
Yeah.
There's many surgeons that do top surgery, either breast removal or chest reconstruction or breast augmentation for clients in Louisville. But as far as bottom surgery, you have to refer them to different cities. There's many different places around the country that can do that. That's what I know. I'm a therapist.
Good.
Currently, there are more surgeons who do the male surgery for life.
Yeah, over here.
Before we go into phase 2,
I don't have much to add. Excuse me, I have a terrible voice too. I don't have a whole lot to add as of yet. I think that just one comment on the clinical side of stuff. The hormonal therapy is really not that hard. It's no more challenging than picking up anything else that you might pick up along the way. You don't. Might be shocking to hear, but you don't learn everything in med school. So, you pick a lot of it up as you go and as you identify populations that you like working with. And so I think that there's a lot of resources out there. Again, the hormonal part of it is really perhaps one of the more straightforward parts of it. I think that really creating an environment that's welcoming across the board is probably one of the more challenging parts. Plug just for what I do, family medicine, I think part of what we hopefully pride ourselves on is really meeting people where they are. And so, you have to work pretty hard to have the strangest story that I hear in a day. We get people from everywhere with all sorts of life experiences and that sort of thing. And so I think that we get used to hearing a lot of different situations. And so, hopefully part of what we offer is just that openness the willingness to hear who you are and how we can help you. And then as far as resources in the city, I think that Louisville is getting there, but trying to create a more formal network is really what our ultimate goal is. I think that both Lori and I are interested in creating an LGBT clinic. It's a little easier than simply hanging a shingle that says LGBT clinic, as you might imagine. So institutionally trying to create the support and the financial support really to make that sort of thing happen. Anybody who's interested, we'd love to bring you along. It's something that's going to take some time and take a lot of effort from a lot of people to see happen. But I think that it needs to happen. We all recognize that Louisville's the most progressive city in Kentucky, which doesn't mean a lot. But at the same time, I think that being that we tend to be a hub for a lot of LGBT people who like Kentucky, don't want to move out of Kentucky, but this is maybe the only place they want to live in Kentucky. I count myself among those. So I think that it's time for us to do that, and these are the initial steps that we're taking. And we need to leave just a little bit of time for the cases because we put in our objectives, and so we want to make sure that you have that. But
are you all continuing to see a high rate of uninsured LGBT? Are you able to recognize that as clinicians have?
I think that's definitely improved. Moving actually from student health out of student health, I'm seeing less uninsured. There was, with the Affordable Care Act starting to get fully implemented, I think that helped incredibly.
I guess, I'm coming from the perspective of evaluating the Affordable Care Act, and how do you evaluate outcomes goals? Because you don't check a box on the application for Connect. It says this is my gender identity.
Well, and that's part of the problem, right? Is that it's not. I don't see uninsured people, but I see people who have very similar problems with their insurance. So, are you lucky enough to have identified on your insurance as your preferred gender, or were you identified as the gender that you were assigned at birth? If so, then what's your insurance going to cover? If you're a trans female and we need to order a PSA, how does that go? If you're a trans male and we need to do a pap smear, I think that those kinds of things are the harder parts to negotiate. And luckily we have a pretty close relationship with a couple of the insurance companies here in town. And so we're just kind of feeling that out as we go. I think the insurance companies aren't quite sure what to do with it. The EHRs, insurance companies, driver's licenses, everything is you have one of two choices, right? And so there's not, that spectrum really isn't reflected yet. And so trying to figure out how that works going forward is one of the big challenges. Our part of that is really easy, right? I mean, we just ask you who you are and how you'd like to be addressed. Trying to negotiate that with the insurance companies is a slightly different story. So, any other question?
Question about that is the contact center.
Absolutely, and I think that that's part of the network we had. Identifying therapists who work a lot in the transgender population is very helpful because then that allows them to also help their clients get into medical care and vice versa. As far as the plastic surgery, again, I'm still new to figuring out who does what just as much as anybody. So, I mean, I know that the top surgeries are technically less challenging. The bottom surgeries are much more so. It's news to me that we have a lot of people here who do top surgery. I think that most of my patients who I've spoken with about this oftentimes go out of town. But that will be part of what we eventually like to do is find surgeons who do this. I think that what you find is that places that create LGBT clinics tend to then attract other providers who want to work with LGBT patients. So hopefully, we can create this and then have surgeons come in, help us out. All right. That said, I think that some of the tables on the periphery perhaps don't have cases. So if you don't have a case on your table, please take a minute to move interiorly. We have one table smack in the center that has some seats available.
And if
then
you're by yourself, then you're not going to have anyone to talk to. So you
Right.
need to join a table with others.
Slightly less collaborative if you're sitting by yourself. We're going to give you about 5 minutes to read the cases, and we'll circulate around, and then we'll have some discussion.
Yeah, there's nothing I can resist. My husband and I really that. See, that's what I love with my med students. I do all these cases, and I make them do all the work, and then I can just say, look, you guys do everything, and I didn't have to do anything.
You did great. I was actually going to ask you.
Well, and then I knew, but then I even fixed that.
Then I would have converted it.
Well, and the thing is I can convert back on my computer. It looks like everything is fine, and I even had to fix a couple things on it. Those ones where
Just how it goes.
You're by myself.
I can't write down this. Oh, you did? Okay, great. Yeah, definitely. Sorry, I didn't get a chance to introduce myself, but I'll move my back. Yeah, this is so cool. Yeah. Okay, yeah, definitely.
Yes.
Okay.
Yeah.
Okay.
You'll find it.
Yeah.
I mean, that's what we know.
Yes.
I know. That's why I'm sitting here. I'm like, because, right. And that's what I'm like, yes. Yeah, and I know. Well, I know she. Okay, good. Like, I know she's. That's really good. Yeah. Right. Okay. Yeah. Nice to meet you. Yeah.
Oh,
All right. So we're just about out of time. Do we want to take some time to just reflect on the cases quickly, or are we enjoying our conversation sufficiently? All right. Let's. We've had one overwhelming vote for reflection. So, could somebody who has case number one, who's feeling talkative, give us a very brief 1 or 2 sentence summary of case number one? Excellent.
Okay, so case number one is about a 14-year-old adolescent named Jamie, who was assigned male at birth, and then at age 12 comes in with mom for referral to a therapist due to some depressive symptoms. And in speaking with the therapist, ends up talking to the therapist about thinking that he may be gay. Therapist discloses that to his parents. Therapist has sort of a bad response to that, and then I guess ends up in the doctor's office and is starting to sort of or transition a little bit, and has a bad experience with office staff, and then comes in sort of trying to discuss things with the provider about just feeling different, and it doesn't just feel like I'm gay, I just feel different, and talking about it anyway.
Sure. Good.
So questions for us was how do you, if you're providing care, how do you meet this individual's needs?
outcomes who may be at risk for, how could we help with this? And we're giving for the phone of school, providing parental support, possibly getting him to a different other risks could be for substance abuse, depression, suicide, poor school performance. And then again, just, we talked about star and support the family.
Good. Anybody else with case one have anything else to add? Yes.
Well, one kind of a throwaway paragraph in there was there.
Right. Absolutely.
One.
That's a great question. Sure, but it illustrates the point that you want to. I think that it's important to give Jamie space to be Jamie and to really feel out. Jamie's clearly kind of like Lori discussed in the presentation. Adolescence is an incredibly tough time, even if you're cisgendered and heterosexual. And so to be anything other than that, or not even know what you are, you just got to give people a chance to be who they are, and then you're just simply a reflecting board. And then you go from there, try to figure out how you can help them out. I think that the point about your staff is very important as well. I mean, that's so difficult. But the nice thing is that we have a resource here. The LGBT Center is happy to come and help train your staff in sensitivity and creating an affirming and approachable environment. Moving on to case two quickly. Anybody summarize? All right.
So Michelle presents to an OB-GYN office, a gyn-onc office with a recent discovery of cervical cancer that's spread, stage 3, spread into the pelvic wall and onto the kidney. The staff is a little bit confused by the patient's presentation and struggles with pronouns. The staff, because Michelle outwardly identifies as male. There were a couple things in this case that were confusing, by the way, because the case author said that Michelle identifies as butch woman.
Yeah, I didn't understand.
So, there's some kind of maybe gender fluidity or gender nonconforming. We may not need to think about being gender binary here.
Or just confusion in the case. It's hard to tell.
Okay, or just confusion in the case. By the time the clinician gets to Michelle is upset and kind of pacing and upset by the way she was greeted at the door, and the staff person who greeted her said, this is an OB/GYN office and we see women here, and she felt judged by other patients in the waiting room and really was feeling out of place there. Michelle had not had any preventative care for the last 20 years because of a history of sexual assault. And Pap smears brought a lot of that to the surface. Michelle is recently unpartnered after the death of her partner of, 35 years, and is not sure that she wants to stick around for care because what difference will it make anyway? So the question one was, if you were providing care, what would you do to meet this individual's needs? I first said apologize for the staff at the front desk. Another member of my team with a little more experience said, maybe you don't have to start there. Maybe you just start with, hi, Michelle, my name is, how do you want to be identified? And then we only got to question 2. which about social determinants of health playing a role in how the patient is presenting. So, again, binary, non-binary, is this a heterosexual or a lesbian relationship? If Michelle identifies as male, then socially, this is a heterosexual relationship that Michelle has been in. If Michelle identifies as female and Butch woman, then this would be a lesbian relationship. So there's some, gray area there, which is great. And of course, her sexual assault is playing a role here. So complicated. We didn't get past 3 or 4. So if other teams want to tackle those.
Any other groups that had case 2 that has comments or additions? I think one of the main things is how do we approach Michelle? And I think if you're not certain of the gender identity of a person, I think the best way to approach them is to ask them, what do you prefer to be called? And have them tell you how you should be approaching them. So in a sense, it doesn't matter what she presents as in this case, because we could have just asked her. And again, that comes back to the staff training, because that was where the incident occurred. Yes, please do.
Or is that rather, how would you like to be addressed?
Yes.
Yeah, rather than called. Called has just bad connotations.
I think that one of the main points of this case too is also just to point out that remember that the populations at highest risk for dying of the cancers that we screen for are the ones who don't get screened. And so if you scare patients away, if you have an environment that is not open and welcoming for getting screened, these people then are immediately at higher risk. And so, Michelle has an advanced cancer and is thinking about walking out of the clinic because it's been such a shitty environment so far. And that's terrible. And so thinking about, what do we do to fix that? How quickly, what do we need to do to make sure that we create that environment such that somebody's not dying from something that we could have prevented, or in this case could have treated. Last case.
I guess I can do that. We had case 3. Carlos is a 29-year-old male with a history of anxiety and depression that presents to the dentist with evidence of erosion and decay of the tooth enamel and evidence of bulimia. And then Carlos confides in the dentist that he has had problems with bulimia. And we basically, also, just to mention this, he said that he was bisexual, and the last time he came in for a checkup, he had overheard some homophobic jokes, and that had made him upset. I was a little, obviously, when that kind of thing happens, you kind of apologize to the patient for, how that experience. But it also says that was like 7 years ago, so I was kind of confused about whether or not it was then or 7 years ago or whatever, but that still should be addressed with him, I think. And then when we discussed it, we were basically saying this is from a dentist perspective, that the dentist would, just be kind and supportive with them, and then refer them to a doctor, a family practice physician or a general practice physician that they could get established with, and then that physician could refer them to psychiatric services and stuff like that really has where his other issues can be addressed as far as the bulimia goes. And if he hasn't been, we were saying that if he hasn't been to a doctor in a while, or if he hasn't been to the dentist in a while, he probably hasn't been to the doctor either. And so getting him established with a primary care provider and getting him is the first step that's important. And then getting him into therapy and other areas, getting him treated and examined for long-term consequences of what could have happened from the bulimia and whatever other health issues he may be having that haven't been attended to. So
good. Anyone else with case 3 that has any other comments on that?
Well, it does talk about how he reported that anxiety ever since he was kicked out of the house by his parents. So, I mean, a lot of that talks about other social determinants on top of that anxiety, just the
Exactly. And I think even if it is 7 years ago, that seed has already been planted as far as I'm not going to be welcomed or well received. I'm not going to walk into an inclusive or accepting environment. And so that all has a contribution to whether or not we decide to access care. And adding on to that is, the fact that they may not have family support. We kind of presume that people will have family or other social supports, and that's one thing that's lacking, which may be contributing to his mental health status. It definitely is, yeah. Yeah, very good. Other comments, questions? Okay. Well, I'd like to thank everyone personally for coming out today, and I appreciate it. I'll be hanging out for a few minutes afterwards if anybody has any additional questions or networking opportunities, whatever you'd like to do, talking about resources, etc. So thank you again.
Thank you so much for being here today and for learning along with all of us. Dr. Pendleton, Dr. Kaloya, thank you for your time and putting together this really helpful, thought-provoking, and useful presentation for us. And before people leave, it is my duty and honor to ask you to fill out your evaluations. They help us tremendously in improving this certificate series. So I greatly appreciate your comments there. You can leave them on your tables. I don't mind going around and picking them up from your tables. You're more than welcome to do that, or just hand them directly to me. Thank you. Have a wonderful rest of your day. If you have any questions for us, feel free to ask.